welcome to the Aaron Werner podcast on iCode Media. We've got a full house today. Been looking forward to this conversation. But before we jump into, I want to have you all meet our esteemed guest in the virtual studios because they're all over across the country. So we'll start with Dr. Walt Whitley. Walt, tell us a little bit about who you are and who is Walt.
You bet. Hey, thank you so much for having me on here. Excited for our conversation, especially having Hardeep here too. My name is Walt Whitley. I'm the Director of Professional Relations and Education at Virginia Eye Consultants in Norfolk, Virginia. I do see patients about 3.5 days a week. I get that question a lot. Do I still see patients? I do oversee the dry eye center within our tertiary referral clinic.
Nice. And Hardeep, where are you coming from? Tell us about you.
Thank you so much for having me this morning. I have a practice in Porter Ranch, which is a small town just north of Los Angeles in California. And Avant Eyes Optometry and Advanced Dry Eye Center, I opened as a cold start about 3.5 years ago.
Oh, very cool. And that accent is not an LA accent.
That is not, no. So I am originally from England, but I've been in the United States a very long time.
Nice. So you, by default, you're now the smartest person on this call because if you show up with a British accent.
Definitely.
Excellent. And Roger, tell us a little bit about who you are.
Yeah, thank you for having me as well. My name is Roger Kennedy. I'm the Senior Director of Marketing for BioTissue. I've been with BioTissue now just under 8 years. I was originally from Jamaica, but I don't have an accent, so go figure that.
Yeah. So I don't know if the Jamaican accent would have made you the smartest person. Probably
true.
the coolest person in the room.
Yeah, I was gonna say probably a different vibe, but you're stuck with the plain language Roger for now.
We can handle it. So thank you guys for being on here. The impetus for this conversation, I was chatting with a couple of my colleagues and my business partner and Roger and Kit, who works on his team. And I made the comment, we were talking about one of BioTissue's newer products, CAM360. And I made the comment that I'm not a fan. And they were blown away. And I said, well, we probably would be fun to have a counterpoint as to, why people like the different products. I love the fact that there's multiple and that we get to choose. But I thought it would be neat to have this discussion as I was doing pre-recording discussion with the team here. I said, this is think of us as all sitting around having a beer together or a cocktail, although where I'm at right now, it's 8:00 in the morning. So we're not going to talk about what's in the coffee mug.
No judgment.
That conversation is fun, and I love those as a practicing optometrist and clinic owner. And so I thought that we'd bring some friends on and have that discussion as well. So before we jump into it, for those who are not familiar with BioTissue's lineup, Roger, do you want to just give us a quick rundown of the different products that you're seeing currently or you have available in the market for us?
Yeah, for sure. I'll start with a couple products that aren't really, I guess, relevant to this conversation, but BioTissue in general are the makers of cryopreserved amniotic membrane. And so that looks like a lot of different forms. Surgically, we have amniograft, which is in a sheet form. It's cryopreserved amniotic membrane in a sheet form, in a variety of sizes used for a variety of applications. We also have AmnioGuard, which is umbilical cord, once again, in multiple sizes for multiple applications. And this is ranging from cornea specialties to glaucoma surgeries, to oculoplastics, and kind of some stuff in between. More relevant to today, we had Prokera, which was our flagship product. It's still a bit of a flagship product to us as well. Cryopreserved amniotic membrane, well studied, over 440 peer-reviewed studies on cryopreserved amniotic membrane. The CPT code was established specifically for Prokera and its cryopreserved amniotic membrane. And so we felt really confident in that product, what it does, the clinical benefits and outcomes that are associated with it. But for a long time, we've heard that the ring, right, which is something that a lot of people had a hard time dealing with. Whether or not it was detracting enough to not use it or stop using it, or they do use it, but just wish that it could be a little bit better or was a little bit more comfortable for patients. And so we got to work and decided to provide another option, another delivery mechanism for cryopreserved amniotic membrane in the form of our newest product, CAM360, CAM360 amniograft. And basically what that is similar to Prokera's cryopreserved amniotic membrane. It was designed to optimize comfort. That was the intent of the product. To do that, right? It's still cryopreserved. It's still a hydrated piece of tissue. We actually added an additional benefit or feature to it that it's shelf stable. The reason why probably some doctors aren't as big of a fan of it as others is probably twofold. One, they never had a problem with Prokera, like they were just fine setting expectations. And the ring, I think different doctors have different comfort levels, right? With Prokera, if it's not a problem, like, hey, why do something? Full disclosure with CAM360, we get the benefit of not having a ring. It's a ringless design. It is more comfortable than Prokera, but the assembly of CAM360 and the fact that it's hydrated is a little bit more tedious than just a simple placement of the ring right inside the eye. So that's kind of the pros and kind of where we thought of where it sits for us personally as a company. We don't care, what you use, right? We just want you to have the option. We do think that there's probably a place for both in a practice, right? As you get to more severe indications, things like non-healing defects, corneal ulcers, Stevens-Johnson's, things that are really, really severe. We do think Prokera has an obvious place and a solid place. I think where things get a little bit muddier or there's potential overlap is as you go down to that kind of SPK, central SPK, that kind of area where it's got a kind of a preference thing and maybe even patient factors that are involved in that as well.
Perfect. Very comprehensive overview. Thank you. And I think that leads perfectly into, the question that I'll just throw out to Walt and Hardeep is, how do you use this in your practice, right? In clinic. If you guys are like me, I hear the rep and they've got the perfect talking points from the companies and very helpful, but it's kind of like learning how to drive. I don't drive like my driving instructor taught me, 10 and 2 and constantly checking the mirrors. Now I can drink my Starbucks coffee, eat my California burrito. And somewhere in there, I've got a third hand to drive with. So, Hardeep, I'll start with you. What products are you using in clinic? Kind of how do you differentiate them if you're using multiple? How do you see all this?
So I started off my journey with biotissue in the space of using Prokera Slim. And just like Roger mentioned, I wasn't really initially identifying or recognizing that I was having difficulty with Prokera Slim. In most of my patients, I was able to set expectations, identify obstacles for use, and get the patients in for treatment. And I was having very successful outcomes, specifically for moderate to severe SPK from dry eye disease, stage 1 neurotrophic keratopathy, which I'm going to talk about in a few seconds. And those were, and then some infectious etiology, for example, a contact lens related bacteria ulcer. And those, I think, would encompass the 3 major cases or applications, maybe some pre-surgical EBMD if I'm co-managing that with my refractive surgeons. And if I had this conversation with Roger maybe a couple years ago about, I don't think I have a need for CAM360 in my practice because my patients are doing fine with Prokera Slim. And then as I started to implement CAM360, I started to think about how will I implement this? I realized that there is a good application for CAM360 with, I will say, milder stage 1 neurotrophic keratopathy, where I'm not necessarily seeing consistent, persistent breakdown of corneal epithelium, but I do have that reduced corneal sensitivity, and patients are kind of waxing and waning with this mild SPK. So a mild dry eye case or a milder stage 1 neurotrophic keratopathy is a really good candidate in my practice for a CAM360 treatment. Patients who are not candidates for Prokera Slim because of ring discomfort, I think that's the big obvious one. Maybe folks who had tried Prokera Slim, and then if I mention that treatment, maybe in 6 months, they say, oh, I don't think I could do that again. And I love having CAM360 in my pocket to say, well, I actually have a product that can be just as therapeutically beneficial for your condition, and you won't have the discomfort of the ring. And then I do co-manage quite a bit surgical glaucoma patients in my practice, and they're coming over from glaucoma surgeons for management of what they are initially diagnosed with dry eye, but end up having neurotrophic keratopathy. And those patients are not candidates if they've had surgical blebs, tubes, trabs, etc. for a Prokera ring. In that case, that's a really good candidate for a CAM360. So I think for me, it was identifying the gaps that were not necessarily so obvious to me with Prokera Slim, and then fitting CAM360 into the gaps and realizing that there is a need in my practice, but I do still lean on Prokera Slim for more of the, I would say, progressed, not advanced, but more progressed cases. And for stage 1 NK, I think it's really important for us as we're identifying to start thinking about early stage 1 and more moderate to severe stage 1, borrowing a little bit from the neurotrophic keratopathy study group, where they sort of break down stage 1 NK, and we start to see this sort of mild loss of corneal sensitivity, but we're not necessarily seeing this very obvious breakdown of corneal epithelium. I really like CAM360 for those patients. So that's how it fits in my clinic.
Cool.
For me, Aaron, first, we do have student drivers, and so it's actually 4 and 8 now. It's been updated, and so just want to make sure I got that out there for y'all next time you drive.
4 and 8.
I think the only things to add to what Hardeep mentioned is do something. And so I've tried them all, do cryopreserve, tried the dry membranes, and they both had a place. I said had a place in my clinic. I never had issues with Prokera because, I worked with biotissue. This was even before Prokera Slim, but had the thicker rig. And, they started to support optometry. And I did a program for them where they wanted all their team to know what role optometry plays within ocular surface within surgical. And so, I'm always big on supporting those who support you. And so that's I do want to make sure I say that. With Prokera, with my success with the ring, I haven't had the pushback from majority of patients because it's all about education. And so I tell patients, someone who broke an arm, they have a cast there, they don't need it there. Your eyes are sick. I have an amniotic membrane. It's going to come in a ring. We're going to put this on your eye. And so we need at least 2 days. I try to keep it about 5 to 7 days. But if you have any issues, just let me know, and then I'm happy to, I can see you sooner and take it out. Actually, one thing that I did totally off label is actually give them comfort drops, kind of like we did for PRK, and so diluted proparacaine. And since I did that, haven't had an issue. So use something. I say cryopreserved because it does have the heavy chain hyaluronic acid pentraxin 3 complex. So pentraxin 3 is part of the immune response. The heavy chain hyaluronic acid is the anti-inflammatory complex that has the regenerative properties. It has anti-inflammatory, anti-scarring. And so there's many benefits to that. I used to lecture and tell people you need to, try a dry membrane before the CAM360 came out. And one of the issues that I had is we were getting hypoxia. And so we're just putting something that's wound covering. It doesn't have the regenerative properties, putting a contact lens on it, creating more hypoxia. And then I started seeing these infiltrates that were happening. And so I started prescribing antibiotics combined with steroids to try to minimize that. And so I just did not see the response. We have 4 cornea specialists within our practice. And so between all of us, we've tried dry, we've tried cryopreserved. Our go-to is cryopreserved. Now, if you're asking about CAM360 or Prokera, we do have patients. Hardeep mentioned those patients. They had a Prokera, neurotrophic. When we treat it the first time with the Prokera, these are chronic conditions. So we're going to see that patient again. And then, when we come back, if they say, hey, I understand I need it, but I would rather use a softer lens or a collagen shield. And so that's where it comes in. Or the other case is we know our patients best. We're doing a lot of ocular surface disease. I've been seeing some patients for like 10, 15 years, and I know their personality. And so that's where I'm like, hey, we're going to do a CAM360 right away. And so that's all I wanted to add to what Hardeep mentioned. But all the disease states, I do the exact same thing as she does.
Yep. No, I appreciate both the inputs. Hardeep, you brought up NK neurotrophic keratitis, and I want to go back to that for a little bit because I think that if you're in that world and you're reading the dry literature, that's not foreign to you. But for some, it may have been something they learned about in school. They vaguely remember their professor pulling out the dental floss, and you're thinking, "Wow, this is weird." Is this mint or cinnamon? And stabbing people in eyeballs. So let's break down how you, and Walt, I'll ask you the same question. So how do you identify a neurotrophic keratitis patient? How do you test for it? And then probably equally as, if not more important, what are you specifically documenting in the chart to establish medical necessity, so that when and if you do get audited on, why you're using a Prokera, your chart reflects the reason why. And I think that's probably the one area of optometry they didn't emphasize enough in school, and we still have some lacking on, is really defining the medical necessity. We find it, we're just not defining it. So walk me through. You've got a patient in the chair. You suspect NK. What do you do from there?
Okay, I'm sorry if I forget to answer a question. Just remind me if I get lost.
No, of course.
So firstly, let's talk about the characteristics of neurotrophic keratopathy. So what we understand is that there's a very intricate relationship between corneal epithelium and the corneal nerves that are in the layer underneath the epithelium. And the epithelium and the corneal nerves support each other. They are releasing growth factors, essentially in tandem, to help each other heal. If we start to see a breakdown of corneal nerves, let's say that we have risk factors such as chronic contact lens wear, which is a risk factor for neurotrophic keratopathy. So we're starting to see a breakdown of corneal nerves. Chronic exposure to preservatives and glaucoma medications like benzalkonium chloride. We know that that causes inflammation on the surface. It can start to break down corneal epithelium. It can start to cause harm to the corneal nerves. Certain ocular surgeries, multiple ocular surgeries, diabetes, for example, multiple sclerosis, for example, these are all risk factors for neurotrophic keratopathy. You start to get a breakdown of that corneal nerves, and then the corneal nerves, when you look under the slit lamp, the corneal epithelium is starting to break down. So you could see SPK in stage 1 NK, you might see a frank open epithelial defect. And the tricky part about just using a slit lamp examination to identify neurotrophic keratopathy is that you can't functionally see the nerves. You can't physically see them. So you may be missing disease. And the way that we identify NK is it's characterized by a reduction in corneal nerve sensitivity. The functioning of corneal nerves isn't there. If the corneal nerves, what I say colloquially is that the corneal nerves are broken, and therefore the overlying epithelium starts to break down. But in early stage, you may not necessarily always see on every patient visit that corneal epithelium is breaking down. We have to test for corneal sensitivity. So the way that I do that, and you mentioned it, is you essentially need to stimulate the mechanonociceptors. And what we're doing is we're touching the cornea and we're looking for an objective or a subjective response. So the way that I do that is that I will use unwaxed, unflavored dental floss. If I don't have that, then I'll use a cotton tip applicator. Just pull the cotton off of the applicator, make a filament, and then I'm touching up, down, left, right, and in the middle. So I'm testing all 5 quadrants of the cornea. And the way that I document that is I'm going to say, is it normal? Is it absent? And if it's anything in the middle, it's reduced. And that's the easiest way for me to remember it. And I document that like a gonioscopy in my exam note. And so under special testing, I will have a chart where it has the 5 quadrants. And BioTissue actually has a really nice schematic tear-off pad that they can provide to practitioners. And it looks very much so like a gonioscopy chart with the quadrants. And then there's a coding system on the bottom that says normal, absent, or reduced. And your technician can do this and then just scan it into the patient chart. So you have that documented. And essentially what we're looking for is, does the patient respond with a blink? And that way we know that we've stimulated mechanonociceptors so our corneal nerves are working properly. Or does the patient tell you that they feel it? So objective versus subjective. Once I have documented that, and I'll summarize it in the assessment and plan and say that we have a 1+ SPK, reduction or absent corneal sensitivity, 2 out of 5 quadrants, worse centrally, whatever that subjective interpretation is, and then start thinking and talking about what treatments are available for the patient. And when I'm talking about and thinking about treatments for NK, I'm really focusing on how do I focus on regenerating corneal nerve density and corneal nerve function, because it's a structure function relationship. If I'm testing for sensitivity, I'm looking at the functioning. I don't have a way in my clinic to look at microscopy and look at the density of the nerves like I can with meibography in meibomian gland dysfunction. So I'm using the sensitivity and I'm using the slit lamp examination to help me understand. And in early NK, if that patient at that visit does not present with SPK and I didn't test corneal sensitivity, I may misdiagnose this patient with dry eye, and then I don't have an opportunity to talk about regenerative treatment like CAM or Prokera. So I'm a really huge proponent of testing corneal sensitivity in every dry eye patient that comes into my clinic, whether it's a referral from a different provider or whether it's a self-referral for further dry eye care. And what I notice and what I find is that it's something, just simply testing corneal sensitivity sets my practice apart from a lot of other practices in my area, because patients will come in and say, well, I've seen 3 other doctors for a dry eye and these are my symptoms, or this is my journey. And we'll test for corneal sensitivity and we'll find a reduction. And now all of a sudden we've opened up a plethora of treatment options that focus on regenerative corneal regenerative medicine instead of just topical anti-inflammatory therapy. Did I answer all those?
No, that was fantastic. Yeah.
The Myopia Collective. CooperVision and the AOA have partnered in a groundbreaking initiative to change the way optometrists in the U.S. treat children with myopia. The purpose of the Myopia Collective is to rally the profession of optometry and its allies to interrupt the status quo and elevate the new standard of care for children with myopia. Every individual is encouraged to become a member of the collective. By joining, you commit to taking action to help slow the progression of myopia in children. You'll receive updates and information about the collective and its work in the fight against myopia, gain access to educational opportunities and resources offered by the collective, and hear from change agents, the ambassador optometrists selected to serve as advocates for community and policy change that facilitates the mission of the collective. Scan the QR code or click on the link in the show notes to join the collective today.
In the past, our focus revolved around prescribing MacuHealth or MacuHealth Plus to patients at risk of macular degeneration, while also recommending it to collegiate and professional athletes for enhanced contrast sensitivity in sports performance. However, this year's introduction of the Life Meter has been a game changer. The Life Meter revealed a concerning truth. Many of my patients have alarmingly low skin carotenoid levels, indicating potential deficiencies in essential body tissues like the retina and brain. Supported by over 30 peer-reviewed publications, Life Meter's accuracy, consistency, and effectiveness has been demonstrated across 2,000 subjects with diverse backgrounds. With this newfound insight, I can now have meaningful conversations about carotenoid levels with all of my patients, even those who may seem outwardly healthy. To learn more about this empowering technology, feel free to contact your MacuHealth representative or click on the link in the show notes. Together, let's optimize patient care and elevate their well-being.
I was going to comment
Walt.
something you just said, Hardeep, is, if we're looking at ocular surface disease, the low-hanging fruit is going to be our dry eye patients, okay? We have numerous dry eye therapies. There's so much innovations in that space, whether they're procedures, whether there's some new pharmaceuticals. Whenever we see that staining, I mean, we have the tools. We have our fluorescein. We may or may not use listamine green. I don't use it enough. I know Hardeep uses it on every patient. But if they come in with 2, 3 plus staining to start with, I mean, that's where we need to check sensitivity. And I was part of a consensus panel. It was 3 cornea specialists and 3 ODs. And one of the consensus was anytime there's 2 plus SPK or more, check for corneal sensitivity, just as Hardeep mentioned. But going back to the drugs, let's see myself or Hardeep, or you see a patient, they come in for a dry eye evaluation, we see a staining, we test corneal sensitivity. We're still going to use our prescription drops. If we put a steroid, if we put lifitegrast, we bring them back in a month, 4 to 6 weeks. If they still have staining that doesn't improve, that's a high suspicion that they have NK, and then we need to intervene sooner. And that's where the CAM360, that's where the cryopreserved membranes do come into play. As for checking corneal sensitivity, I move very quick, so I do not check all 5. If I see the staining, I check in the middle. And is it present, reduced, or absent? I don't check all 5 because the treatment's not going to change for me. But in the different quadrants, when you'll see that is going to be herpes. I've been teased. I run a herpes clinic because we have 4 or 5 cornea specialists in our group. And so normally wherever that ulcer was, that's where they're going to be more desensitized. And so that's where I would focus my sensitivity. But I only do one area, and that's all I wanted to add.
No.
I think that's a really great point, Walt, is that, if you are not checking sensitivity at the outset of a dry eye consult and you're seeing these patients, you're thinking about how can I make changes tomorrow in my clinic? Well, we're looking at these patients where we've essentially almost run the gamut of treatments on these patients. They've had cyclosporin, they've had lifitegrast, they've had multiple rounds of plugs, maybe you've done topical steroids, and that SPK is persistent, it's stubborn, or it's waxing and waning. You do a course of steroids and maybe there's an improvement. We're super encouraged by that. Reduce the steroid and the inflammation comes right back, and that epithelium starts to break down again. That is a great clue into maybe something is happening at a deeper level than just the surface on the corneal epithelium.
Yep. No, I agree 100%. I had a conversation probably a year or two ago with Nate Lighthizer, and we talked about how much we're treating the symptoms in ocular surface disease and not discovering the problem, and the underlying problem way too often is neurotrophic keratitis. And I think we, at least pre that conversation with him, in my mind, it was that, horrid looking cornea that was essentially dead, not paying attention to that real subtle NK. Right? We go
So to add to
scenario.
that means we all see NK, because we've heard feedback from our colleagues. Oh, I never see NK. I mean, if you've seen a dry eye patient, you've seen in a mature patient, as we grow up, wrinkle, gray, dry up. I mean, they're going to have NK if it does not get better. That staining.
Yep. I completely agree.
How long does it take? Well, I test like you do, right? My business partner, and she's fantastic. She's much more thorough, if you will, like Hardeep and systematic. I pull out the dental floss and just dab and go through. How long does that take you? Are you doing it? Do you have techs doing it? How do you have that set up?
I do it myself. And one of the things that I make sure all of our technicians know, and as part of our protocol, is not to do any tonometry, because oftentimes they're so used to checking that pressure, our technicians. And so I always have to put no touch on those patients so I can check it. But it doesn't take very long. I mean, just grab that cotton tip applicator and twist it up and then just test for it.
So perfect. And I think it helps us, not that this is a financial discussion, but I'm not running a nonprofit. I don't think either one of you are running a nonprofit. And, at the end of the day, the business of healthcare is business of healthcare, and we need to be able to reinvest back in our practices. And so establishing that medical necessity reason, not just so that we can look our patients in the eye and say, I need to put an amniotic membrane on you because of XYZ reason. But when our charts do get audited and somebody looks at it, you've got clear establishing reasons for the medical necessity.
Yeah, and so part of my assessment, I do have failed therapies, failed lifitegrast, failed cyclosporins. Yep. You put that on there, and also that corneal sensitivity. You need that on there because that just helps justify the reason why you did it. Because some people might argue, oh, it's just dry eye, that you don't need it, but you've documented the need.
By the way, can I go on record saying I despise that phrase? It's the dumbest phrase ever. It's just dry eye.
What's that? Everything
I hate the phrase dry eye.
It's just dry eye.
I hate the phrase dry eye. No, you were using it appropriately. I despise that phrase because it doesn't tell me anything other than they've got a problem that I could probably have already figured out. Right? It doesn't give me any reason why. It doesn't give me any more information than I have a car. Well, that's nice, right? Is it new? Is it old? Is it gas? Tell me about it. Mm-hmm. So being able to, and I think it's important for patients too to say not just you have dry eye, but you've got meibomian gland disease, you've got neurotrophic keratitis, you've got whatever the case is, because now we're giving them helping them understand why they're having the problems they're having. Hardeep, to your point, when you see patients that have seen 3 or 4 providers and nobody's been able to fix it because they're all just trying to treat the symptom of dry eye, not figuring out what the problem is.
So then one of the pearls to that is, educating the patient. I mean, that's key in anything that we do. Mrs. Smith, your eyes are sick. You've tried these different drops. This is why they are working. We have to get those nerves working better. And this is where the cryopreserved membranes such as CAM360 come in.
Yep. So that brings us to the debate that I wanted to have, which is CAM360 versus original Prokera. And Walt, like you, I missed the original big fat membrane that we just get to slap on, and it sat there. I think that in optometry, we are way too good at minimizing problems for patients. I think we try to belittle the problem, if you will, and as opposed to making it more serious or as serious as it is. And you just said, hey, you have a sick cornea. We try to say, oh, your cornea is just a little bit dry, or we can do this, or we can do that, right? No, it's sick. It's diseased. And I think we naturally shy away from big, scary words because we like to give good advice. So I try to use the big, scary words so that patients understand this is serious and they need to follow through. I also like my treatments not to cause pain, but sometimes discomfort has a value. And so if you're going to have a big ring in your eye and it's going to be discomfortable for the next 3 to 5 days, that's me telling you and you reminding yourself every day, this is serious. I wouldn't be putting you through something if it wasn't serious. My goal is not your comfort. My goal is your health, which is one of the reasons why I default to the ring significantly more than CAM360, because I kind of want to inflict that discomfort in them so that they realize psychologically this is a big deal. But Hardeep, how do you explain not just the disease state to patients, but when you are going to put a Prokera or CAM360 on, what's the verbiage you use?
I talk about the properties of I use the word contact lens because it helps introduce the idea that there's going to be a lens, a foreign body in the eye, and most people understand the concept of a contact lens. So once I have their attention with that word, then I'll say, this is a placental derived treatment, and there are properties in the placenta that don't exist in an adult body that we need to capitalize on so that we can heal the deeper layer. And the problem's not just on the surface, but a much sort of deeper problem. And so we need we don't want a baby treatment for a severe problem. We need to match the severity of the treatment to the severity of the problem. And I kind of use that and say, what we're doing right now is a baby treatment to help them visualize. And then I think to Walt's point earlier, patient selection is very key in success, because this treatment is, I think we all understand, is not just a one and done forever. There's going to be some repetition in the future, and setting the patient up successfully for the first treatment, I find, then helps the patient continue treatment in the future with Prokera or CAM360. So
I'm going to interrupt real quick there. For those who are listening and not watching, Hardeep is amazing at how she uses her hands when she's educating. So I would make a mental note for yourself to go back and watch the YouTube version of this. We're about 30 minutes in, and just how she describes and uses her hands to follow the storytelling along is exceptional. So most people listen to it, but I wanted to make sure we call that out, because you do a really good job of not just the words you use, but also the gestures along with them.
Thank you. I'm sorry. I didn't realize it would be an audio option as well. So I do want to educate patients on the biological properties is essentially, the summary of that. And then identifying appropriate patient selection. If the patient psychologically, they're very anxious about their schedule and being able to fit in, I need to have this uncomfortable ring in my eye, I don't think that's going to be a great candidate for Prokera. And then in that case, a CAM360 is a much better option, helping them identify obstacles in advance. I do need to tape your eyelid shut, so maybe we're not going to do this before your Thanksgiving dinner. So helping them identify what obstacles are upcoming, and also allowing them to understand this is going to be, 2-3 day treatment. This is what works for my schedule in my clinic. I typically do 2 or 3 day treatments, and then come back and I will remove the tape. So you don't have to touch, you don't have have to do anything apart from just have that membrane in your eye and continue any necessary eye drops, whether that's a compounded antibiotic or glaucoma medication. But other treatments like a cyclosporin, I will not continue that. So helping them understand what the next couple days will look like, I think, is also very important in explaining how they'll be successful in treatment.
I like that.
You know, I think we have to go back to the properties, right? The anti-inflammatory, the regenerative properties of the cryopreserved membrane. And so, once again, main thing is do something, right? Whether it's going to be a Prokera, whether it's a CAM360, CAM360. Many of our colleagues, they've heard, the rings hurt, that, and so that's why BioTissue came up with the CAM360. So now we have an option that is for that has those growth factors that are going to help our patients. So for me, I'm like you, Aaron. I've always been a Prokera guy. So what I've challenged myself to do is I don't do a study of 1 or 2 or 5, and so I challenged myself. Hey, I got to do 25 CAM360s, and I'll still alternate between the Prokera. But I do want to say, I want to see for myself, is it making a difference, or how is it different? Am I hearing anything different from my patients? But there are many strong properties of the CAM360. Main thing, once again, is doing something for our patients.
Well, let's dive into that a little bit, because I'm really glad you brought up the N of 1. And quite frankly, I don't give a damn what Mrs. Jones thinks, because Mrs. Jones is only one Mrs. Jones in the entire world, and she may be super cool and normal, or she may be the crazy cat lady. I don't know, right? So I love the fact that you said you don't do the N of 1 or the N of 3 or the N of 5. What was that, Roger?
No offense to cat ladies for those.
Yeah, no offense to cat ladies, but I want to paint that mental image, right? So when you do your 25, and I think that 25 is a great number. I think 15 is a great number. Pick a number, right? Double digits. How do you keep score? So do you keep track of that? Do you've got a list you're writing down? How do you make sure that you don't turn that I'm going to do 25 goal on the front end into I used it on 2 people and they didn't like it, and so I'm done, or I didn't get the results that I wanted? How do you set that up? Help us walk through that so we can do the same thing in our clinics.
Well, I mean, I already know what my patient's been saying for a decade when it came to Prokera, so that one's easy. I'm not, for the CAM360, to be upfront, I am not tracking everything like I typically do. Normally, when a new drug comes out, when a new device comes out, I would do, let's say, some of the MGD procedures. I would start, what's their speed score? What is their tear film breakup time? Get that at baseline and then follow up. For me, I'm just looking at my efficiency within the practice. I know how the cryopreserved membranes work, so I'm confident in the outcomes of it. And so I don't track it as well. My issue is seeing, how quickly I can do it, but then is it delivering the same results that I've seen consistently for over a decade?
Oh, yep. I like that. So if it wasn't something you were... Oh, go ahead.
Sorry, I was just going to add that I think if somebody is looking to identify or somehow quantify, I think an anterior segment picture with staining is a great tool, and also helps encourage the patient to see before and after pictures of outcomes.
Actually, one more thing. This is an easier way to grade. All right. So Tom John, he was part of a study, right? And so he had patients on maximum medical therapy versus a Prokera for 5 to 7 days by itself. And pain score. On average, the pain score was 7. After 5 to 7 days of a Prokera or amniotic membrane, that pain score at 1 month down to about a 2. At 3 months, it went down to about a 1. So that's another thing you tell patients. Hey, you know how your eyes have been feeling. I'm not talking about NK right now because they don't feel it anyway.
Right.
But for those dry patients that are feeling that pain, I say, hey, you've been feeling this way. This is why we're going to do it. This is what the data shows, and then we just do it.
Yep.
Yeah, that's a great way.
You bring up an interesting point, and I'm trying to remember who I had this conversation with because I want to give him credit. I'll probably think of it tonight. But they said that if you're going into the gym and working with a trainer at the gym, the trainer doesn't set your goals for you. You set your goals for you. Do you want to lift heavier? Do you want to run faster? Do you want to lose weight? Do you want to look better? Like, what is your goal? Because they're all different goals. And one doesn't always derive the other. I'm dealing with that right now. I'm in marathon training and my pants fit better, but I still haven't lost a pound. But so I think that sometimes in clinic, though, we establish the goals for the patient. This is going to do that when that might not be their goal. And so they end up unhappy because we set expectations for them that were different than their own expectations instead of asking. So perhaps it's pain on the front end. Perhaps it's being able to wear their contact lens longer. You may actually, in their mind, make things worse if you've got a severe NK patient that you're healing the nerves on, and now they start feeling things, and they're starting to feel worse before they feel better. But establishing their goals and working with them, and then writing that in the chart and always going back to it, I think is a fantastic, not only clinical pill or pearl, but practice management pearl, because you can always go back and remind them what they initially came in for. And if it was pain reduction, or discomfort reduction, that's what we've got.
Actually,
They
one
may
more.
not care what the picture looks like.
Here's
as long as
another
they feel
metric.
better.
This one's easy, right? Vision. Right? And so whether it's going to be a pre-surgical, post-surgical, or not even surgical, they're like, oh, I can't see 2025, 2020. It just doesn't look sharp. Well, you do it, and then afterwards, they're like, oh, I can see better.
Yeah.
And so you'll hear it from your patients how this benefits them.
Quality. And be sure to write it down, because they'll forget that when that becomes their new norm.
Yeah.
And right. But I love that on the quality.
Yeah,
So
for us, I'll just say, there's a lot of different aspects going on with obviously I'm biased, right, being with biotissue and the benefits and all that. But as long as the patient like feels better and sees better, I think that's like the two main things. You can go down into being more granular in a lot of different ways, but those are the two metrics that we really hope our products achieve.
I like that, Roger. So I've asked both Walt and Hardeep to share how they present it. When I talk to patients, I let them know that I'm looking for them to feel better and see better. And then I'm looking for me to be able to look at their health and have that improve, because that's something that they can't always see. So you've got goals, I've got goals, and hopefully those two sets of goals are aligned. But I'm going to walk through and document. And I don't think that takes a whole lot of time. I think that takes 3 minutes, which is the other reason why I like Prokera versus CAM is it's a little bit quicker to set up.
Well, once you get to 25, Aaron, it'll be quicker.
Yeah, 25.
It's very true.
I just
You're in CAM training, just like Marathon.
I'm in CAM training. CAM patients in my office in full disclosure go to Brittany. She my business partner loves CAM360, and so I grab a Prokera, rinse it off for a little bit, tell them it's going to sting, put it in. They say it stings. I said, I see, I told you. And we laugh for a little bit, right? We're going to tape it down. I still struggle with the falsy eyelashes. I pulled the set off accidentally with tape. And you want to make somebody mad, you pull off their false eyelashes on one eyelid. Yeah, now I've got teenage daughters, and I understand more
another
why.
thing to add, because you just talked about your partner. So within our practice, we have about 13 ODs. We have 34 providers. I will tell you, the majority of our ODs, they've gravitated toward the CAM360 just for that comfort.
Yep.
And they're quicker than me.
You brought up multiple providers, and I've got a thought on this, but I'm curious, Hardeep and Walt, your guys' thoughts. Why are still a significant number of our colleagues, I don't want to use the word afraid because I don't think it's a fear factor, but why are they not incorporating cryopreserved amniotic membranes into their practice? What do you think?
I'm going to answer this based on feedback that I get from, community doctors is cost. Is just the revenue aspect of having a, very frankly, cheaper dehydrated membrane, for example. Maybe they do have a very good understanding of the differences in the biological properties for each, but at the end of the day, sometimes revenue is making those decisions. This is what I hear back from my community doctors. Walt, do you have anything to add to that?
It is some people say they don't see that NK patient. I mentioned that earlier. And so they're not even thinking about, what are some of the other options for our patients? Try this drop, try another drop. Maybe it's an MGD procedure. I think that's one of the things but that's even with dry eye itself is, are we looking? Are we asking the questions? Are we looking at the not just what the signs, but what is their quality of their vision? What's the quality of their symptom?
Yeah. Oh, good feedbacks. Let me throw this out, because here's what I think, and I think that the cost certainly can play a part. Not looking, seeing the disease state, not being aware. I think that that optometrists, we like happy patients. We're in a profession where we can make people happy pretty quickly. I fix your glasses and contacts, and most of, our injuries and diseases that we deal with, we can address pretty quickly. Even the chronic ones, we can make them get them comfortable quickly. I think that we're afraid of the unknown in that first patient and not knowing how they're going to react. And the reason I say this is because when BioTissue first came out and Prokera first came out, all the reps had the little like retractable lanyard that they would pull the lens out, but nobody could touch it because it was expensive. And so they wanted to show you. And it took a long time for me to convince my rep to bring in some lenses and let my docs put it on each other. The minute the docs put it on, I heard a couple things. Number one, oh, that was it. Right? It wasn't this crazy over the top procedural experience. It was like,
it's very underwhelming as the procedure.
Very underwhelming. It's easier to put on than a soft lens. Because I don't care if they're blinking, I can still shove it up into the cornea and tuck it under the lid, right? And then when they took it, and then when they tried it on each other, they said, oh yeah, it stings. And they said, yeah, it's going to sting for 60 seconds. And at 60 seconds, it was gone. Left it on for 5-10 minutes. And then they pulled it off. And the doc who had the lens on goes, oh, that felt good. I like that. And so I think having that hands-on experience of the first win, knowing that the patient was going to leave and it was an easy procedure for the practitioner to do, I think helped them get over the initial fear factor hump. And then I think once you have that one crazy patient where you're like, I don't know how this is going to end up, right? I've got a nasty scar I'm dealing with. I've got super bad NK. Usually we wait till we save the newest products for our worst patients. But when it works, then you have the success stories and go, okay, now I know where this plays a role. Because I think that gets past I'm just going to use the dehydrated because they're cheaper, right? The dollar goes out the window when you can see the actual effect of it. So the reason I share that is because I think if you haven't played with it, Roger, I'm going to spend your money now, but call your rep and play with it, right? Put it on your eye, put it on a partner's eye, put it on something, just get your hands on it. You're not going to hurt yourself. You're not going to hurt them. But have that experience in a safe place where you can ask questions, where you can laugh and feel what a membrane feels like in your hands, because it feels kind of silly and whatnot. But I think we just need to get over the fear factor sometimes.
Yeah, if you get a chance, there's always workshops. And whether it's the rep bringing it in, I mean, I've worked with the BioTissue team. We just did a workshop with Pacific University. Once you get your hands on it, you're like, wow, this is something that's easy. This is something that I should do. And then we all have those patients. So finding those patients. And then you just mentioned, some of the dry membranes. I'm going to go back to that support. Being involved with organized optometry my whole career, you have to support those that support your practice. And so that's why, I've been working with BioTissue for many years now too.
Yeah, and I just want to add that I think the fear factor may also play into how do I bill and get reimbursed for the procedure. And I think I don't know where the perception comes from that I'll be audited. If I hear this a lot, that I'll be audited if I do X amount of membranes. I'm not sure where it comes from, but I do hear it. And I think the BioTissue has an absolutely phenomenal practice integration program that the rep can educate doctors' offices about and really get them plugged in with helping understand using Pinnacle, which is a group that helps understand insurance and how to bill to insurance and what codes to use and how to fill out the CMS forms, navigating that reimbursement aspect and implementation on the back end once you've treated the patient. Use those resources. They're amazing.
Yep. 100%. I think that some of the fear factor comes from, well, one, we're always afraid of the audit monster, right? And once you learn the rules of billing and coding, and I'm going to nod to Chris Wolf and team. They've got excellent, just in general, billing and coding education. You don't have to be afraid of the audit monster because it's what it is. It's just like being afraid of the highway patrolman, right? You know what the speed limit is. You don't got to be afraid of him anymore. Unless you're consistently driving 95, in which case, good luck. And I think that that's where the stories come from, because there are individuals who abuse everything. And so we've heard the stories of the practices that are doing 100 Prokeras a month. And odds are that's not going to happen. And so certainly somebody's going to audit them, and there's fraud happening, but that's the 0.00001%, right? And in reality, if you've got your medical necessity documented, as we talked about, if you're doing things appropriately for the patient, you're fine. And that way, when you do get audited, because insurance companies have to, audit, you send in your documentation, they go, okay, cool, thanks, bye, right? Here's your check, you're good to go. You don't have to worry at all about it. And I agree 100%, Hardeep, that the resources that BioTissue as a company is invested in to make sure that we have all these questions answered is phenomenal. I also, Walt, to your point, as we look to wrap up, not only has BioTissue focused a lot on optometry, but we get a significant number of referrals now from our surgeons, not just glaucoma, but our retina, who's doing tons of injections and whatnot, kicking back in telling patients you're going to go back to Werner and they're going to put a Prokera on because what I've done has killed your cornea, and I want to make sure that we maintain the front part of the eye healthy. My job as your retina doc is to maintain the back of the eye. Their job's to maintain the front. And so it's been really interesting seeing that discussion back and forth. And maybe I've hit the jackpot in reps, but our reps are not trying to tell the surgeons, hey, you guys can do this and get an extra, payment on taking care of the patient. They're saying, no, send it back to the optometrist who knows the front. You deal with the back, build that relationship so the patient ultimately gets properly taken care of. And we're seeing tons of success with that. So I like that discussion. Well, as we wrap up, Walt, Hardeep, Roger, any final thoughts?
I'll
go. Hey, thank you so much for having us on this podcast. Love this discussion that we're having. I think the main thing is do something. The benefits of the cryopreserved, your patients are going to benefit in the end.
Yeah, thank you for a really wonderful discussion. I think we talked a lot about different topics, and I definitely learned a lot. I always learn so much from all of you, so I really appreciate it. Thank you.
Yeah, I echo the thanks as well, and take you up, Dr. Warner, on spending BioTissue money. If anybody has any questions or just wants more experience, we're happy to do wet labs and provide resources, whether that's the billing and coding stuff mentioned by Dr. Kataria and Pinnacle, whether that's just integrating practices and helping with flow, things like that, or obviously product knowledge. Hopefully you have some great support there as well.
Awesome. Well, thank you guys. I will put, for the listeners, I'll put lots of references that we've talked about in the show notes. So if you wanted to get in contact with everyone, or you want to know more about the billing and coding stuff, there'll be plenty of resources in there. You can always reach out to me for more info as well. Thank you guys very much. Hope you have a wonderful rest of your week and look forward to catching up soon during conference season.
Thank you.
Great.
Thank you.